Dear students, welcome to today's session on cirrhosis and fatty liver and its dietary regimen. Liver is the body's chemical workshop. It is integral to most metabolic functions of the body and performs more than 500 tasks. About 1500 ml of blood per minute circulates through the liver and exits via left and right hepatic veins into the inferior vena cava. The liver is affected due to various reasons like virus or toxic substances, alcohol and drugs, leading to hepatitis and other diseases which may progress into cirrhosis and chronic liver failure, affecting the normal functioning of the liver. The main objective of this session is to understand the progression of cirrhosis and fatty liver, to explain the dietary regimen which is to be followed by individuals with cirrhosis and fatty liver. First, let's see on cirrhosis. Cirrhosis is a condition in which the liver cells deteriorate gradually to chronic conditions. It is a chronic liver disease due to diffuse necrosis and regeneration, leading to an increase in fibrous tissue formation, disrupting the normal liver structure. Scarring of the liver is also known as fibrosis and it may lead to cirrhosis. It is a serious and irreversible disease. Vitamin A deficiency favors the formation of cirrhosis. The buildup of scar tissue in cirrhosis is usually slow and gradual, wherein early stages the liver continues to function, but when the replacement of healthy cells by scar tissue increases, the condition worsens and lead to chronic liver failure, which is also called end-stage liver disease. Its process may commence many years before it becomes clinically obvious, and it is mostly diagnosed at a very late stage with complications such as ascites, ruptured esophageal varices due to increased blood pressure in vein entering the liver, and it may cause sudden bleeding and hepatic coma. Even when almost 85 to 90% of the liver is damaged, it does not produce any symptoms. The initial changes in cirrhosis is widespread liver cell necrosis due to viral hepatitis, alcohol, etc. This necrosis results in collapse of the liver cells and intrahepatic shunts due to the proximity of the hepatic artery and portal vein to the central vein. The necrosis and collapse also stimulate nodular regeneration and fibrosis. Cirrhosis of liver is the structural and functional end result of nutritional, infective or toxic changes in the liver. Next, let's see the etiology of cirrhosis. First, viral infection. The hepatitis virus B, C, D and E more likely to produce cirrhosis. Alcohol. It has a direct effect on liver functions. Acetaldehyde, a toxic byproduct of alcohol metabolism, causes damage to mitochondrial membrane structure and function. Acetaldehyde is produced by multiple metabolic pathways, one of which involves alcohol dehydrogenase. It occurs after years of excessive alcohol intake in individuals whose diets are less than optimal in a number of nutrients. It is estimated that daily 60 gram alcohol for men and 20 gram for women taken over a prolonged period of time increases the risk of cirrhosis. A chronic alcoholic is often deficient in proteins, carbohydrates and vitamins. These make the liver highly vulnerable to any infection or toxin. Alcohol is also known to have direct action on the lipid metabolism in the liver by enhancing fatty acid synthesis, decreasing fatty acid oxidation, producing specific stimulation to triglyceride formation leading to fatty liver, decreased release of lipoproteins and enhanced uptake of circulating lipids. Alcohol can cause deadly damage to the liver. It enhances B and C hepatitis infections and exacerbates drug toxicity. Malnutrition. Malnutrition aggravates any injury to the liver, particularly vitamin A, B complex and vitamin E and C. Moderate to severe malnutrition is a common finding in patients with advanced liver disease. This is extremely significant considering malnutrition plays a major role in the pathogenesis of liver injury and has a profound negative impact on prognosis. Numerous coexisting factors are involved in the development of malnutrition in liver disease. Inadequate oral intake, a major contributor, is caused by anorexia, dysgeusia, early satiety, nausea and vomiting associated with liver disease, and the drugs used to treat it including diuretics, bile acid, sequestrants, neomycin and lactulose. Other causes are related to dietary restrictions and unpalatable hospital diets. Maldigestion and malabsorption also play a role in malnutrition of liver disease. Steatohepatitis is common in cirrhosis, especially if there is disease involving bile duct injury and obstruction. The medications previously mentioned may also cause specific malabsorptive losses. In addition, altered metabolism secondary to liver dysfunction causes malnutrition in various ways. Micronutrient function is affected by altered storage in the liver, decreased transport by liver synthesized proteins, and renal losses associated with alcoholic and advanced liver disease. Abnormal macronutrient metabolism and increased energy expenditure can also contribute to malnutrition. Finally, the protein losses can occur from large volume paracentesis. Toxins of food. The aflatoxin may be one of the causes of cirrhosis. Chilies and spices are irritant foods. When absorbed, are likely to damage the liver cells. However, the effect of such substances on the liver is not yet clear. Metabolic disturbances such as hemochromatosis or Wilson's disease can lead to cirrhosis of liver. Indian childhood cirrhosis is a common disease in India. The clinical and histological features are similar to those of adult cirrhosis. Usually, they are seen between the age of 1 to 3 years, but even babies less than a year old may show an advanced stage of disease. Next is primary biliary cirrhosis. It is a chronic cholestatic disease caused by progressive destruction of small and intermediate sized intrahepatic bile ducts. 90% of the patients with PBC are women, and this progresses slowly, eventually resulting in cirrhosis and may result in death. This is an immune mediated disease in which serum autoantibodies, elevated immunoglobulin levels, circulated immune complexes, depressed cell mediated immune response are present. Several nutritional complications from cholestatic can occur with PBC, including osteopenia, hypercholesterolemia and fat soluble vitamin deficiencies. Next, let's move on to the symptoms of cirrhosis. It could be classified as external and internal symptoms. First, external symptoms. Icteric scleria, which is where the eye is yellow due to jaundice. Next is alopecia, the hair loss is noticed. Asterixis, which is a disorder of motor control and also known as flapping tremor. Palmar erythema, which is the reddening of the skin on the palmar aspect of the hands. Gynecomastia, enlargement of male breasts due to hormonal imbalance. Caput medusa, which is also known as the palm tree sign, which is the appearance of distended and engorged superficial epigastric veins, which are seen radiating from the umbilicus across the abdomen. Ascites, accumulation of fluid, serum protein and electrolytes within the peritoneal cavity. There is altered hair distributions, testicular atrophy, edema, spider angioma, jaundice, bruising and muscle wasting. Next, let's move on to internal symptoms. First, encephalopathy, which is a clinical syndrome developing in advanced liver disease, which is characterized by 4 stages of progression. In the first stage, there is mild confusion, agitation, irritability, sleep disturbances and decreased attention. And in the second stage, lethargy, disorientation, inappropriate behavior and drowsiness are seen. In the third stage, somnolent but irascible, incomprehensible speech, confused and aggressive behavior when awake are noticed. And the fourth stage, coma, is noticed. The next symptom is esophageal varices. The other symptoms include portal hypertension, which increases collateral blood flow and can result in varices in the gastrointestinal tract. And these varices often bleed, causing a medical emergency. And the treatment includes administration of alpha adrenergic blockers to decrease the heart rate, endoscopic banding or varicose ligation, radiologic or surgical placement of shunts. During an acute bleeding episode, somatostatin analog may be administered to decrease bleeding, or a nasogastric tube equipped with an inflatable balloon will be placed to tamponade bleeding vessels. Hepatorenal syndrome, which is functioning renal failure without anatomic or histopathologic renal changes associated with cirrhosis and ascites or with obstructive jaundice, are noticed. And the tea-colored urine are noticed, and there are chances of clay-colored stool too. The medical nutrition therapy for cirrhosis. It is evident that positive outcomes with parenteral and enteral nutrition in malnourished patients with cirrhosis, including improvement in nutritional status and clinical status. Next is the dietary regimen for cirrhosis. Before appropriate nutrition therapy can be implemented, a nutritional assessment must be performed to determine the extent and cause of malnutrition. Many traditional markers of nutritional status are affected by liver disease. The principle of diet includes a high calorie, high protein, high carbohydrate, moderate or restricted fat, high vitamin diet. This helps in regeneration of liver and helps to prevent the formation of ascites. Low fat with supplementation of fat soluble vitamins and minerals should be given. Sodium should be restricted only when there is ascites. Fiber should be restricted when there is danger of esophageal varices and portal hypertension. The diet should be attractive and palatable. Energy. The energy requirements vary among patients with cirrhosis. Several studies have measured resting energy expenditure in patients with liver disease to determine the energy requirements. Ascites slightly increases the energy expenditure. In general, the energy requirements for patients with end-stage liver disease and without ascites are about 120 to 140% of the REE. The requirement increases to 150 to 175% of the REE if ascites infection or malabsorption is present, or if nutritional repletion is present. This equates to about 25 to 35 calories per kilogram. Next is the carbohydrate. Determining the carbohydrate needs is often challenging in liver failure. It reduces glucose production and peripheral glucose utilization. The rate of gluconeogenesis is decreased with preference for lipids and amino acids for energy. The carbohydrates should be given liberally so that the liver may store glycogen. 60% of the calories should come from carbohydrate so that liver damage is minimized. Next is the carbohydrate. Determining the carbohydrate needs is often challenging in liver failure. It reduces glucose production and peripheral glucose utilization. The rate of gluconeogenesis is decreased with preference for lipids and amino acids for energy. The carbohydrates should be given liberally so that the liver may store glycogen. 60% of the calories should come from carbohydrate so that liver damage is minimized. Next is the lipid. In cirrhosis, the plasma-free fatty acid, glycerol and ketone bodies are increased in fasting state. The body prefers lipids as the energy substrate, and lipolysis is increased with active mobilization of lipid deposits but the net capacity to store exogenous lipid is not impaired. A range of 25 to 40% of calories as fat is generally recommended. The coconut oil with medium chain triglycerides can be given as it is digested and absorbed in the absence of bile salts. Protein. Serum albumin, which is exclusively synthesized by the liver cells, is low in cirrhosis and aggravated by the loss of a considerable amount of albumin into ascitic fluid. A high protein diet is helpful for regeneration of the liver. In the absence of hepatic coma, a high intake of proteins, about 1.2 gram per kg body weight, can be given. If the patient is in pre-coma or coma, the protein should be withheld till the patient tides over the crisis. The protein content of diet varies according to the symptoms. The increased amounts of proteins can be met by the addition of casein, which can be added in milk, soups and ice creams. The vegetable proteins containing more valine is beneficial in preventing encephalopathy. Vitamins and minerals. The liver is the major site of storage and conversion of vitamins into their metabolically active form. In cirrhosis, the liver concentration of folate, riboflavin, nicotinamide, vitamin B12 and A are decreased, which may be due to decreased synthesis of retinol binding protein. Since vitamin D is converted into calcidiol in the liver, oral administration or injection of vitamin D in biliary cirrhosis is not successful in raising the serum level of calcidiol. Vitamin supplementation, especially of B vitamins, is required to prevent anemia. Choline and methionine are useful if fatty infiltration is present. Sodium is restricted in edema and ascites. In patients with cirrhotic ascites, dietary sodium intake may initially be restricted to 400 to 800 mg per day. Restriction of fluid intake is required for patients with hyponatremia. If there is no ascites, very little salt is permitted to make food more appetizing. Potassium salt is administered for ascites and edema to prevent hypokalemia. Anemia is common and supplementation with ferrous sulfate, about 0.3 gram tablets 3 times daily after meals, is recommended. Folic acid, about 1 mg per day orally, is indicated for the treatment of macrocytic anemia. If patient cannot maintain a sufficient intake by eating, supplementation with sip feeding should be considered. If this is inadequate, enteral supplementation should be considered. Parenteral nutrition should be reserved for patients in whom enteral nutrition is unsuccessful and to be given only for short time. Due to risk of catheter sepsis and poor resolution of ascites, parenteral nutrition is not the best choice of feeding. Hepatic, herbal supportive, antioxidants and maintenance of adequate calorie, fluid and electrolytes, fat-soluble vitamins are routinely recommended. The problems in feeding include anorexia, nausea, dysgeusia and other gastrointestinal symptoms. The adequate nutrition intake is difficult to achieve. With ascites, early satiety is also a frequent complaint. Smaller, more frequent meals are better tolerated than 3 traditional meals. In addition, evidence suggests that frequent feeding also improves nitrogen balance and prevent hypoglycemia. Oral liquid supplements should be given to malnourished patients with liver disease if their intake is less than 0.8 gram of protein and less than 30 calories per kilogram of body weight, and if they are at risk for fatal complications of diseases. Foods to be included are lean cuts of meat, fish or poultry, skimmed milk, egg whites, cottage cheese, starchy foods such as potatoes, rice and cereals, coconut oil and safflower oil with medium chain triglycerides. And the foods to be avoided are high sodium foods such as salty foods, salt in cooking and salt in usage at a table must be avoided. Preserved foods such as canned foods, sauces, soups and pickles contain high salt content, hence it must be avoided. Then eating out must be avoided. Caffeinated beverages, fruit juices, tea, soda, gelatin, spices, high fat foods, raw foods, especially salads and raw vegetables must be avoided. Alcohol must be completely restricted. The next condition which we are going to see is fatty liver. Fatty infiltration or hepatic steatosis or fatty liver is a condition characterized by the accumulation of excess fat in the liver, commonly caused by alcohol abuse associated with obesity, starvation, intestinal bypass, parenteral alimentation and diabetes mellitus. The amount of fatty acids in the liver depends on the balance between the process of delivery and removal. Insufficient intake in the form of very low density lipoprotein is also a reason for fatty liver. It occurs commonly due to moderate to large quantities of alcohol consumption. The fatty liver is caused by culmination of these metabolic disturbances. 1. An increase in the mobilization of fatty acid from adipose tissue. Second, an increase in hepatic synthesis of fatty acid. The third reason, a decrease in fatty acid oxidation. And the fourth, an increase in triglyceride production. And finally, a trapping of triglycerides in the liver. The major cause is obesity and overweight. About 75% of obese individuals are prone to fatty liver. Starvation, malnutrition, prolonged parenteral feeding, rapid weight loss, insulin resistance, type 2 diabetes mellitus, hypertension and hyperlipidemia are also causes for fatty liver. The other causes include genetic factors, chemicals and drugs such as corticosteroid, tetracycline and carbon tetrachloride. It can be due to metabolic abnormalities such as glycogen storage disease, homocystinuria, tyrosinemia and galactosemia. The alcohol-induced steatosis does not show any symptoms. Only in case of severe fatty infiltration, the symptoms like malaise, weakness, anorexia, nausea and abdominal discomfort are noticed. Icterus is present in 15% of the patients admitted in the hospital. The hepatic steatosis is not generally chronic, but it is progressive, leading to fibrosis, cirrhosis and liver cancer. The next is non-alcoholic steatohepatitis. It is more severe form of fatty liver in which the alcohol consumption is not a cause. This causes inflammation in the liver cells. It is different from that of alcoholic fatty liver, which is mostly benign. Up to 20% of the adults with non-alcoholic steatohepatitis develop into cirrhosis and 11% may lead to death. This is also common among children in whom there is an alarming increase of childhood obesity. Next, let's move on to medical nutrition therapy for fatty liver. No specific dietary restrictions are needed in cases with simple alcoholic steatosis. This condition causes a deficiency of various vitamins, minerals and trace elements, and hence it must be kept under consideration while planning a diet for alcoholic fatty liver patients. Malnutrition being a common found in these patients, it may progress into cirrhosis, hence consumption of adequate nutrients is recommended. Weight loss must be gradual and must be controlled. Exercise must be done on regular basis for weight management. Nutrition and lifestyle education is the mainstays of therapy. Consumption of a well-balanced diet, low in saturated fat and high in fiber is ideal. Hepatic steatosis is reversible with abstinence from alcohol. Conversely, if alcohol abuse continues, the cirrhosis can develop. To summarize, the high calorie, high protein, high carbohydrate, moderate or restricted fat, high vitamin diet is recommended in case of cirrhosis, and a low fat and high fiber diet is recommended along with weight management in case of hepatic steatosis. Thank you. Hope you have understood on cirrhosis and fatty liver and the dietary regimen.